So we are starting in 3, 2, 1. We are live now.
Good evening, friends. Welcome to the Thursday evening webinar series of the PG Track Delhi CSI. And once again, I have the great pleasure to welcome you all on this webinar, the 32nd one webinar of the CSI Delhi branch. And today we'll be having the second part of the lecture series of the X-ray chest in cardiology. How do we interpret? We'll be digging more deep into the interpretations. And on this beautiful journey, we have Dr. V.S. Narayan. Sir gave a terrific lecture last time. And along with me in this journey, I have Professor Sumodh Kurian, Professor of Cardiology from GV Pant, my colleague, Professor Girish MP, my co-colleagues, Dr. Sanjeev Kathuria, Associate Professor of Cardiology from GV Pant, and Dr. Deepti Sridharan, Associate Professor of Cardiology from All India Institute of Medical Sciences. In case you have any questions and clarifications, please type them in the chat box. They will be reaching us and we'll try to answer all the relevant queries. In case you miss out the lecture, you have missed the last week's lecture, don't worry, you can subscribe to the channel of BG Track CSI Delhi branch and listen to that talk. And there's some interesting announcements in the end, so I would request you all to stay on this journey today with us. So over to you, Dr. Sumodh, for starting today's session.
Once again, a warm welcome to all. Last week, as Dr. Mohit told, we had a very excellent lecture from Professor Narayan sir. As you all know, sir was the HOD at KGMC Lucknow, and you all would have enjoyed last week's lecture. And sir has left us all in a great expected note last week. So I don't think you can wait any longer. So I don't want to prolong. I warmly welcome sir. Please come and teach us on X-ray interpretation, congenital and valvular heart disease.
Thank you, Dr. Sumodh. Sir, if you can unmute yourself and start. Unmute yourself. Dr. Narayan, if you can please unmute yourself, sir. Narayan, sir, if you can unmute yourself.
So the host has to do it. Do I hear you now?
Yeah, perfect, sir.
Can you hear me now?
Perfect. Please go ahead.
Okay. So let's, friends, thank you very much for being here again. And it was wonderful discussing with you the X-ray findings on the last meeting. And we went as far as the left atrial enlargement and the blood flow was concerned. So the pulmonary venous hypertension part we have covered and the blood flow part we have covered. So let's go on a little slow as we did last time. And we'll go on to the criteria for judging left ventricular enlargement. So PA views, of course, are not the views for ventricular enlargements, but then some of the pointing features could be a rounding of the cardiac apex, and much talked about obtuse angle which the apex of the left ventricle makes with the diaphragm, the so-called cardiophrenic angle. There is an elongation of this axis, long axis from the base to the apex, goes down to the further from the fifth intercostal space to the seventh and downward. So that is the elongation of the axis. And you find that the apex is gone just below the diaphragm. So these are some of the pointers which we could say could mean a left ventricular enlargement, although this is not the best view to say for enlargement. So we go to the lateral view. And in the lateral view, there are, if you go very simply, if you look at the space between the cardiac shadow and the spine, that space should be empty. If it is full, this means that is left ventricular enlargement. When we turn the patient from the PA view, when we screen the patient, so what we say is that at a left anterooblique view of about 60 degrees, the left ventricle should be able to clear the spine. And if at 60 degrees it is not clearing the spine, it is likely that the LV is enlarged. But in the lateral view, obviously, that space between the ventricle and the spine should be clean. If it is full, then it's likely to be left ventricular enlargement. And there are two measurements, the regular measurement and the Eylea ratio, and we'll discuss them. So we have the Hoffman regular sign. It is often examined. It is often in exam questions. And when we say this, it says, how do you actually measure and what is the objective methodology for saying that left ventricle enlarged. So in the lateral view, when you look, you find that this is the left ventricular border, and inside the border you have the IVC. And when you take a measurement, the Hoffmann-Rigler's A, you take a point, let me tell you, we take a point 2 centimeters above the point where the IVC cuts the dome of the diaphragm. So you go 2 centimeters up, and from this point you measure this distance A from this point to the outer border of the left ventricle. And this, if it is more than 17 millimeters, it is a normal situation. If it is less, then you know that this is an enlarged left ventricle. The more it enlarges, the more is the distance from this point. So this is Hoffmann-Rigler sign. Sometimes the patient, the examiner can ask you this question. This is not left ventricle enlargement because this distance is definitely more than 17 millimeters. This is basically to show you right ventricular enlargement, and we'll come to that later. But the criteria for right ventricular enlargement also is that when you have an obliteration of the space between the sternum and the ventricle, you will have a negative Rigler-Hoffmann sign. So one of the criteria for RV enlargement is obliteration of the space and absence of the Hoffmann-Rigler sign. But let's forget this and just concentrate on this 2 centimeters above from the point where the IVC cuts the diaphragm, and from that point you measure the outer border of the left ventricle. It has to be more than 17 millimeters to be called a enlarged left ventricle. And then you have the Rigler-Hoffmann's B measurement, which means that from a point where I will come to that. If you look at this, from the point where the left ventricle cuts the IVC, that is the point which you have to take. And from that point, you drop a perpendicular onto the diaphragm. And this distance should normally be 7.5 millimeter or more. And if it is less, this means that this is a left ventricle enlargement according to Rigler's point B. So you take a point where the left ventricle cuts the IVC, and from that point you drop a perpendicular down to the diaphragm, and this distance should be normally more than 7.5. It is less, then it is suggestive of left ventricle, because the larger the enlargement, the distance will be smaller and smaller. So these are the two A and B measurements in the Hoffmann-Rigler sign that you can subjectively say that the patient has a left ventricle enlargement. Otherwise, simply speaking, if you find that this space which exists behind the ventricle and the spine, this is full, this is evidence of left ventricle enlargement, simply speaking. But sometimes the examiner may like to ask you the subjectivity and objectivity. So objectivity is in Rigler-Hoffmann sign. Now, often you may not be able to see the IVC. So then the Rigler sign will not be applicable. And there you have to take the Eilers ratio. Now, this is a simple ratio where the left ventricle meets the diaphragm, that is point B. And from there, you draw this horizontal line. This is distance AB. And from there, you have the border of the vertebrae. This is distance BC. And as it is obvious, the larger the left ventricle, the longer will be AB and the shorter will be BC. So the ratio will keep on increasing. Normally, this ratio is less than 0.42. But as this distance AB increases because of left ventricular enlargement, this ratio will become more and more. So if you have a ratio more than 0.42, this is Eilers ratio suggestive of left ventricular enlargement. So these are the two measurements that some examiners may ask you, and you may come forward and say that the Hoffmann-Rigler's point A and the distances A and B, and the Euler ratio, the values being 17 millimeters, less than 17 millimeters, and more than 0.42 respectively. So that much for left ventricular enlargement. Now coming to the RV enlargement, as we had said that the cardiophrenic angle in LV enlargement in the PA view is obtuse. Here the angle is acute. So this is simple when you look at the PA view. But once again, the PA view is not the view for saying, and you might have to depend upon the lateral view, and there will be obliteration of the space between your ventricular shadow and the sternum. And the Rigler's and Eilers ratios have to be normal, as we had said earlier. And this is how the space is obliterated. This space is obliterated, and the criteria is that if you measure the distance from the joint, the manubrium sterni with the sternum, you measure this distance, and if the ventricle is in contact with the sternum for more than 2/3 of this distance, it is a criteria for RV enlargement. Simply speaking, this space is obliterated. Now, this space is often also obliterated because you know that this space is occupied by the right atrium. So if there is an obliteration of this part of the space, it is because of the right ventricle. If there is obliteration of this part of the space, it's because of the right atrium. So this also has to be understood. As I said earlier, this space, right atrium, this space by right ventricle, and this is the normal situation. Here you see that this space is not only obliterated, but the ventricle is in contact with the sternum for almost the entire part of the sternum, but definitely more than 2/3 of the distance from the joint here down to the cardiophrenic situation. So these are the two criteria, but this space is empty. There is no left ventricle enlargement. There is no left ventricle enlargement, but the right ventricle is enlarged. And if you would have obliteration of this space also, this will mean right atrial enlargement. Now, once we start talking of right atrial enlargement, there must be some criteria for right atrial enlargement also. And the common criteria which in the examination we are telling our students is that if you draw a line from the midline of the spine and you go to the outer border of the right atrium, this distance should be more than 5 centimeters in adults and 4 centimeters in children. So 5 and 4. And then if there you do not want to measure it, then you can see the intercostal spaces. If it occupies more than 3 intercostal spaces, more than 2.5, some people say. So definitely if the right atrium is occupying more than 3 intercostal spaces, it is enlarged. And if you measure the distance from the medial part of the clavicle down to the diaphragm, and if the right atrium occupies more than 50% of this distance from here to here, this is right atrial enlargement. So these are the 3 criteria which you take for right atrial enlargement. This is normal, this is enlarged, this is more than 5 centimeters. So it is a definite enlargement, 1, 2, 3 intercostal spaces occupied. And this distance, the right atrium is occupying more than 50% of this distance. So all these 3 criteria are met, and this is right atrial enlargement. So from the left atrium to the right atrium to the ventricles, all this is covered. Now let's get to the aorta. And this is the shadow which you normally would not see, but sometimes you do see the shadow, but this becomes prominent when you have some kind of ascending aorta dilatation, as you would see in patients with bicuspid aortic stenosis. You don't see it very often in rheumatic aortic stenosis or even for aortic regurgitation, but in bicuspid aortic stenosis, you have some kind of medial problem with the wall of the aorta. So because of that, you have dilatation of the ascending aorta. So this is almost a straight edge which you see, but becomes more prominent, and we'll see that X-rays a little later. What about saying that your aortic knuckle is or knob is prominent? The criteria used is that you draw a line from the lateral border of the tracheal channel. You draw a line from the lateral border of the tracheal aerogram, and this distance from to the outer border of the aorta should be less than 35 millimeters. In this case, if you draw a line from the lateral border of the tracheal shadow, and this distance is 42 millimeters, so the criteria of more than 35 millimeters is met, and you have a prominent aortic knuckle. Now, unfolding of the aorta, you will get a broadening in patients with hypertension and some kind of degenerative diseases also. You will get a prominent knob of the aorta, and the criteria, as we have just said, more than 40. Now, the descending part of the aorta is generally very smooth. If you take a little penetrating view, you will find that the descending shadow of the descending aorta is very smooth, but it is, I have not seen it much, but in the books it has been described that you can have some kind of irregularity if you have arteritis. You can have some irregularity in the, so perhaps in a penetrated view, you can get some irregularities in patients who have aortoarteritis, such as Takayasu's disease. Now, this is a definitely prominent ascending aorta. This is a picture which is often brought by examiners, and then the viva begins. And this ascending aorta dilatation is because of a bicuspid aortic valve. So AS with a bicuspid aortic valve, a prominent aortic ascending aorta. And this is the descending aorta. And sometimes you describe this hump. This picture gives a picture of a sitting cat appearance. And this is the hump, this is the rounding of the border, which some people say is because of left ventricular hypertrophy. When the borders become a little round and sharper than usual. So if you have a round and sharper left ventricular border, this could mean left ventricular hypertrophy. But this is definitely an ascending aorta dilatation because of aortic stenosis secondary to a bicuspid aortic valve. And this is the descending aorta. Now, when you look at the descending aorta, you have to be careful. Not only if you look at the aorta here, you have to be looking at some abnormality. So the first abnormality was a prominent knob. Now you should also be looking at. Somebody wants to ask anything? Okay. So you have this 3 sign. Now the first knob is because the subclavian artery, the proximal aorta plus the subclavian artery, and this is the constriction, and this is the poststenotic dilatation. So this is the 3 sign. And if you have an esophagogram, this will produce an E sign because it will produce an indentation on the esophagus. And so you have a 3 sign and you have an E sign. And this is produced by the dilated subclavian artery and the proximal aortic part, the constriction and the poststenotic dilatation. But most importantly, you will also have to look at the posterior ribs. And we will blow it up to show it to you. But sometimes you have to look hard on the inferior borders of the posterior ribs to see for rib notching. Unilateral notching, of course, is if you have an anomalous subclavian artery arising from below the quag part. So you will have an aortic. So notching is found in the 3rd to 8th ribs downwards, and it doesn't occur too early. It occurs in about 5 years of time. So all that you should know. The 3rd to 8th rib, you have notching, and sometimes you can have unilateral notching when you have an anomalous subclavian artery arising from below. So this is the 3 sign. Another example of a 3 sign, and this is a blown up picture of the posterior ribs showing an inferior border indentation because of the intercostal collaterals. So this is something which is very nicely demonstrated in this patient, this 13-year-old boy with hypertension. A classic quags, you may not get the 3 sign here, but this notching is definite. And even in this picture, if you look very careful, you will be able to pick up some kind of notching. So the differential diagnosis, you must know coarctation, of course, but you should know that some coarctation of aorta, besides coarctation aorta, you have Takayasu's arteritis, you have subclavian artery obstructions, secondary to classic BT shunts. You can have SVC obstructions, you can have fistulae in the intercostal region, and you can have neurofibromatosis. So all these are causes of inferior rib notching, besides, of course, the collaterals for coarctation of aorta. Now let us look at some unusual. This is also will give you a good comic break also. So look at some of the unusual X-rays that you might be asked to see in the examination. Now what could this be? This could be a very surprising X-ray, and sometimes it kind of puts the student off. But this we used to see in our times when we used to tap the pericardial effusion and put in some air into the pericardial cavity, and thereby you would look at the thickness of the pericardium also. So in our times when you did not have the echo CT, of course, and available, so all that we had was inject air into the pericardium while draining. This could have been accidental, and it could have been sort of done purposely so as to measure the thickness of the pericardium. And this, of course, is a pneumopericardium produced intentionally to look at the pericardium. Now, this is something which is very interesting. See, this has nothing to do with the heart. It is just to show you, something strange can often be brought by examiners to show you. You see, look at these balls. These are ping pong balls. And long before the arrival of the anti-tubercular drugs and and the antimicrobials, some of the methods of treating this infection was to obliterate the lung area which was infected and make it collapse by forcing things externally. It could be, in Hippocrates in 2400, he pushed in pig bladders into the lung, inflate it so as to collapse them and thereby get rid of that infected portion. So this is a situation which we call plombage. And here the plombage was done with ping pong balls, small ping pong balls. And as I said, Hippocrates first used it 2400 years ago and inflating pig bladders into the lung. And this was the usual treatment for TB before the 1950s. Now, this I've just thrown in to revise what we had learned in the last lecture. This is a classic. This is nothing. This is not a peculiar X-ray. This is a classic bat wing appearance of an acute pulmonary edema. So this is just thrown in to get you back to thinking that don't get put off and don't start thinking of any curiosity every time in X-ray. This is not a curiosity. This is something which you will see in your practice. Classic acute pulmonary edema, bat wing. Now, what could this be? This is also a very interesting situation. Unusual X-rays with examiners often being. If you look at this, you would start thinking that this could be a left atrial enlargement. And when you look at the lateral view, you don't find an LA here, but you find something protruding out and obliterating the cavity, and you start thinking that this could be a left ventricle. No, this we have just discussed. So could this be a cardiomyopathy where you have a left ventricle enlargement and you have a left atrial enlargement? I don't see very much of venous congestion here. So what could this be? Could it be something different? Some could be curiosity. Now this is a very curious case. We had an aneurysm of the left circumflex heart. So sometimes examiners can bring you curiosities, and this is a curiosity where you have an aneurysm of the left circumflex. See this big aneurysm in the CT, big aneurysm, and this is seen here as an aneurysm here and an aneurysm. So this is the circumflex region, and you have this curiosity. So I don't think that should keep it in mind, but sometimes you could be encountering. So you must know that aneurysms of the coronary arteries can also manifest as some of these shadows in this. Look at this shadow. Now you would think that this is the aorta and this is the pulmonary artery. But again, this is the area of the left anterior descending artery, and this could be an aneurysm of the left anterior descending. And that is what exactly it was. If you look at this, you find that this is an aneurysm here, and this is an aneurysm which is arising from the left anterior descending artery. Now this shadow, right atrial enlargement. Now what could be the reason of right atrial enlargement? You don't find anything here, but why should you just have an isolated right atrial enlargement? So once again, this could be, since it is in the region of the right coronary artery, this could be an aneurysm of the right coronary, and that's exactly what it was. The right coronary giving, feeding this aneurysm. And if you look at the surgical, you have the right coronary artery, and this is the big aneurysm which is arising. So, sometimes you could be foxed by these images. You could have something here, something at the back, something in front here, mimicking the right pulmonary artery, mimicking the right atrium, mimicking the left atrium, but this could actually be aneurysms. I'm not saying that you should, jump to that diagnosis. But if the examiner prods you and says, can it be something else? Can it be something else? Then you could come out with these curiosities. This patient has another abnormality, just presents with right ventricular failure. Is not right atrial, it presents with right ventricular failure. And on the X-ray, you don't see anything. Now, why should this patient have right ventricular failure? Now, if you take a lateral view, we find something sitting here. And what could this be? This could be a pericardial mass. As seen in the echo, you see this pericardial mass which is pushing on the right ventricle, and that is the reason for his right ventricular failure. You have the right ventricle which is almost, obliterated because of this mass, which is a part of a pericardial tumor. So all these things, can be thought as curiosities. If you get a lateral view and you see something like this, and the patient gives, and you're given a history that the patient presents with right ventricular failure, then this could also be a possibility, a pericardial cyst compressing the right ventricle. A heart within the heart. Now, this is a very curious situation. You have an outer, and this was an X-ray which was shown to one of the examinees. Here you have an ascending aorta dilatation, which is there as a finding, but you have something within the heart. So this is the heart within the heart. And this fellow, when was given an aerated drink, this mass disappeared. That means there is something in the stomach. So this is basically hiatus hernia, which has gone here and giving you an heart into heart situation. If you look at the echo, you find that there is a mass here, but the moment you have an aerated drink, this mass disappears. So this is one of some curiosities which were brought to us in the examination, and I picked them up to show them to you just to break the monotony. And this is a comic break. This is a comic break before we jump to the congenital X-rays. Now, this fellow was a terrorist, and he swallowed this grenade. He swallowed this grenade believing that it will go off in his stomach, but unless you pull the pin, it will not go off. So this fellow survived to get this X-ray. And similarly, this fellow, was an abnormal fellow. He pushed this, this shell, this army shell, this artillery shell up his rectum, and it was successfully removed subsequently. And this one, never propose putting a ring in a glass of milk. A lot of people will propose, put the ring into some kind of drink and then give it to the one you're proposing to marry. And this fellow gave it in milk, so the girl did not see it and drank the whole thing, and his engagement ring went inside his stomach. So just comic breaks before we get to the real business of congenital heart disease. And let's start with shunts. Now, when you look at shunts, you've already discussed that you will get some kind of end on, and you will see vasculature in the periphery, and you will have a main pulmonary artery prominent, right and left pulmonary artery prominent. So this is definitely a case of increased pulmonary blood flow. See this? The main pulmonary artery is prominent, the right and left are prominent, and you see end on shadows, these more than 3 per field or 5 per both fields. But if you see an ascending aorta dilatation, then we are possibly dealing with a ruptured sinus of Valsalva or an aortopulmonary window, or a coronary artery venous fistula. Now, aortopulmonary window shunts are large. You will have more flooding in the lungs. Coronary AV fistula, the shunt is not too large, and you may not get any significant increased pulmonary blood flow. But if you have an ascending aorta prominence, you could be dealing with one of these three. And if you have an arch prominence here, then you could be dealing with a PDA. So if you have ascending aorta and an arch abnormality, a broadening of this mediastinum, you would probably be dealing with one of these 4 situations. The arch pointing to PDA, the root pointing to RSOV, aortopulmonary window and fistula. Now, if you have a narrow pedicle, the aorta is absent, conspicuously absent, and the right atrium is prominent, you could be dealing with a pre-tricuspid shunt such as ASD or a partial anomalous pulmonary venous connection. And if you have a left atrium, then you could be dealing with a VSD. So no significant aortic involvement means a pre-tricuspid or a post-tricuspid shunt, and a prominent ascending or an arch means that you are probably dealing with a PD or RSOV situation. So these are some of the subtle points that will give you pointers as to where the shunt lies. Now, if you look at an ASD, this is the biggest main pulmonary artery. If you do a screening of these patients, you will have pulsating pulmonary arteries, the so-called dancing, the Hyla dance, which you see grossly because the shunts are very large. In ASD, the shunts are very large because of the lower pulmonary vascular resistance. The shunts are quite big, and you see the evidence here. Prominent right and left pulmonary arteries, end-on vessels, vasculature in the third part of the lung fields, and a grossly, But if the main pointer here is that the right atrium is enlarged and the ventricle is the right ventricular type of apex. And if you have this kind of picture, you're dealing with an atrial septal defect. Now, if you don't have that kind of picture, if you don't have a greatly prominent main pulmonary artery, and you still on an auscultation, you've given a finding of wide splitting of the second heart sound and left-right shunt is there, then look at the right border. And if you find that there's a disproportionate dilatation of the SVC with increased pulmonary blood flow, some evidence of increased pulmonary blood flow, the right atrium is also dilated. Think of a partial anomalous pulmonary venous connection into the superior vena cava. Here it is more prominent. Now here it is less prominent, but here it is very clearly prominent. The superior vena cava is prominent here. And this is also prominent. So we could also be dealing here with a figure of 8 situation, that is total anomalous pulmonary venous connection. Because I see some shadow here also. So this could not just be partial, it could be a total, and we'll come to the X-ray of the total anomalous later. But if you get an ESD-like picture, evidence of increased flow, you don't get much of main pulmonary artery dilatation, and the SVC is prominent, you could be dealing with a partial anomalous pulmonary venous connection. Now, this is something which is, commonly, I wouldn't say commonly, but frequently brought by examiners, and you have a finding of an atrial septal defect, and you have this kind of shadow. Very peculiar, very classical, very suggestive shadow, and often missed. So, but you must also, this is the X-ray which people will bring. This is, you just remember this X-ray that they will bring, and this is a Schmitters syndrome associated with it. Lots of things occur with Schmitters, but the prominent would be in ASD, and this is a drainage of a vein, the entire lung, left lung, or a lower lobe of the left lung, the right lung is draining into the inferior vena cava, goes down. So some of the classic pictures of Scimitar. You should remember these pictures in your mind. They will be brought as a curiosity. So one Scimitar, the other Scimitar. The third one, this is also a very common X-ray that many of us have in our stock and we bring. So this is the Scimitar is the Turkish sword, which is after which is be named. So infradiaphragmatic drainage of the right lower lobe veins into the, and there are lots of things which are there as part of Scimitar. That is why I've said etc. etc. But basically it is drainage of this vein at the right lower end. You have an atrial septal defect. Another example of a Scimitar syndrome. This time it is the reverse short. And this is the structures. The pulmonary vein goes down below the diaphragm and joins the inferior vena cava. So this is the vein which is draining down and opening into the, so this is the Scimitar. So you should have the picture in your mind and then will not be. Now from an ASD, let's move to VSD, and we said the most important part of an ASD, this is increased blood flow, because if you draw these 3 lines, you find the vasculature is down. Even if you don't see the vasculature here, these are the end-on vessels which you're seeing, classically indicative of increased pulmonary blood flow. And if you have a left atrial enlargement and a left ventricular type of apex, this is not atrial septal defect, this is ventricular septal defect. Had it been an ASD, it would have been a grossly dilated right atrium, a grossly prominent right pulmonary artery, and a right ventricular type of apex. Now from VSD to PDA, the difference would be, once again, you might get a left atrial enlargement, you might get an LV enlargement also, but here the distinguishing feature would be a broadened base because of a prominent aorta. So aortic knob becomes prominent here, and this is widened. As compared to this is not wide. As compared to in ASD, where it was not wide. ASD, in fact, the aortic stem is narrower than what you get else in a normal situation. So if you have a broadened base and you have a prominent aortic knob with increased pulmonary blood flow, you are probably dealing with a duct. And then look very carefully into the area where the duct is. It is a duct is situated between the aorta and the left pulmonary artery, the main pulmonary artery, which gives rise to the left. And this is the area you should be looking for, the duct. And you see this calcification. This is called a railroad track calcification you see here for the PDA. And that is why when you put in your catheters, you have a move. You go like this and come down. You go like this, go through the duct and come down to the aorta. And you have a hairpin loop type of catheter course. You go from the SVC, you go into the right atrium, right ventricle, RV, outflow pulmonary artery, through the duct into the aorta and down to the descending aorta, and this is the classical hairpin loop. If when you come from above, you go like this, and then you go like that. So hairpin loops are seen when you duct classically. The catheter course would be like this. So this is the difference between the X-rays of ASD, VSD, and PDA. Classic X-ray for PDA, once again, just to show you that this area is broadened, the pulmonary artery is broadened, but the aorta is permanent, and you have cardiomegaly of the LV type. But basically, the differentiating feature would be aorta for PDA, left atrium for VSD, right atrium for ASD, RV type of apex for ASD, and LV type for PDA. Another example of two examples of PDA, increased pulmonary blood flow, and you see this prominent aortic knuckle, so PDA. So this is just to show you all these three. No AS, no aorta here. Right atrium prominent, ASD. Left atrial prominent is VSD, and aortic knuckle prominent, PDA. And this is also a picture which is often brought in the examinations and which you get in your cases also. If you have somebody who has, mild cyanosis and you are thinking of a pulmonary hypertension with reversal of shunt, Eisenmenger syndrome. This is the picture, the jug handle picture of Eisenmenger. You don't have any significant cardiomegaly except when there is an ASD. You have no significant cardiomegaly, but the main pulmonary artery is grossly dilated, and the right pulmonary artery is grossly dilated, and there is peripheral pruning. The distal vessels are less than 50% of their proximal vessels. So this is classic pruning, main pulmonary artery swollen, no significant cardiomegaly. This is a classical jug handle picture of Eisenmenger syndrome. So Eisenmenger syndrome due to VSD, once again, the right atrium, see this jug handle and peripheral pruning. This is basically PD Eisenmenger, this is VSD Eisenmenger. The smallest heart will be in VSD Eisenmenger. The largest heart would be in ASD Eisenmenger. So Eisenmenger, ASD, VSD, and PDA. Now, cyanotic heart disease, we have another 25 minutes. So let's go to the cyanotic heart diseases. And when we talk of cyanotic, we are basically looking for reduced pulmonary blood flow group. The 5 TDS situation, which I say, the 5 T's, DNS, the 5 T's are tetralogy of Fallot, D transposition, L transposition, truncus, and tricuspid atresia. These are the 5 T's. D is double outlet right ventricle, and S is single ventricle. So 5 TDS, where you have a large ventricular septal defect and severe pulmonary stenosis, this so-called tetralogy physiology. So within tetralogy physiology, the anatomical entities would be 5 TDS, which I have just mentioned. So reduced pulmonary blood flow has some common features in the X-ray. There will be no significant cardiomegaly. Now Epstein's also falls in a miscellaneous group, but I have said Epstein's because here also the pulmonary blood flow is reduced. This is functional pulmonic stenosis. So this is not anatomical pulmonic stenosis, but is functional. So except for Epstein's, just forget about Epstein's at the moment. Let's concentrate on the tetralogy physiology, where there will be no significant cardiomegaly. There will be pulmonary oligemia. The exception would be a D transposition of great arteries, where the flow is not decreased but increased. Not grossly increased, but at least increased. The pulmonary base is empty. You see that there is a concavity in the pulmonary region, except for L transposition of great arteries, where it is full, but that fullness is not because of the pulmonary arteries, because of the aorta. Then you have either RV enlargement or LV enlargement, as we will see, and then we'll have some specific shapes which are classical. And this is the first classical shape of tetralogy of Fallot. No cardiomegaly, right ventricular type of apex, because the intraventricular septum has become horizontal and because the RV has pushed the LV upwards. The pulmonary bay is empty and there is pulmonary oligemia. Classic tetralogy of Fallot. In pulmonary atresia, you will have all these features, but you will have a right aortic arch which will be more prominent in pulmonary atresia, and you might also have some degree of crisscrossing in the upper lobes because of the bronchial collaterals. And sometimes you can have a biventricular type of enlargement. But basically, right-sided aortic arch with the dilated aorta and some reticular pattern because of the collaterals which you find in pulmonary atresia. So some slight difference between pulmonary atresia and tetralogy of Fallot. And this is the classic boot shape. You can see it on the echo. You're all very familiar, and you can pick it up also when you're doing a fetal echo. And immediately when you have an overriding of the aorta and a large ventricular septal defect. Now, if you have a cyanotic child and you are expecting this kind of picture, but when you look at the X-ray, you have this picture. Now, what is the difference? The difference is that here you have an RV and here you have an LV. And here you have some emptiness over here. And the right-sided aortic arch, if you look at the indentation on the trachea, it is on this side. So right-sided aortic arch, which is there also here. But the ventricle main difference would be that instead of an RV, you have an LV and some empty space here. This is a classic picture of tricuspid atresia, where you have this absence because of the absence of the RV and because of the juxtaposition of the left and right atrial appendage to this side, and the apex is left instead of right. Of course, you will have an absent main pulmonary artery, that is the pulmonary bay would be empty. So the differentiation would be LV and some degree of absence or straightening of the right border because of the absence of RV and juxtaposition of so this is the area where you should be looking. Diminutive RV and juxtaposed atrial appendage. And this is the difference which you just highlighted, RV here and LV over here. Now, the examiners are very, very fond of bringing this kind of X-ray. This X-ray I have seen, examiners bringing, and myself also I have, taken on several examinations. Now, the student immediately looks at it and says it's tetralogy of Fallot because the main pulmonary artery segment is absent, the apex is upturned. He thinks that this is a soft film, so he doesn't worry about decreased flow, says tetralogy of Fallot. And then I tell them this is patient which is not cyanotic. Then he doesn't know what to say. So I said, whenever you get this picture, always look at the aorta. And you see this 3 sign, this classic coarctation of aorta, some kind of, ascending aorta prominence. And this is a classical 3 sign, and then you look at the periphery. So always look at the periphery and look at the posterior ribs inferior portion. So most of us will say TOF, but when there is no cyanosis, patient is in heart failure, look at the periphery, look at the 3 sign, and look at this doorknob. Now, classic depressions in the lower border. So this is tetralogy. This is not tetralogy, and this is a repeat of what we have shown earlier. So do look in the periphery and do look for notching and immediately think of a coarctation. Whenever you see this X-ray, this will be the X-ray that will be, brought by the examiners. So just ratify it. So this is classical 3 of coarctation of aorta. And this is a picture we've already seen. This is classical 3. Now the question asked is, can this be tetralogy? And the answer would be no. Why? Because there is cardiomegaly. Although there is absent main pulmonary artery segment, but the right and left pulmonary arteries appear grossly swollen. So how can this be tetralogy? But the answer is, can this be tetralogy? The answer is yes, it can be tetralogy. And these are the grossly dilated main and right and left pulmonary arteries because of the absent pulmonary valve. So this is the so-called Mickey Mouse sign, where you have grossly dilated pulmonary arteries because of the absence of the pulmonary valve. And the presentation here would be respiratory distress with hoarseness and everything. So gross pulmonary distress would be the presentation. And this is a curiosity, a Mickey Mouse sign for a absent pulmonary valve in tetralogy. So this is tetralogy with absent. Then the next step, the examiner he will give you this X-ray. And immediately you will say, sir, this is another Mickey Mouse, because you think this is a prominent. And then you will forget that there is so much increased flow in the periphery. In a Mickey Mouse situation, you will not get increased flow. But here you find that there is evidence of increased flow. Lots of end-on vessels are being seen here. This is a classic picture of total anomalous pulmonary venous connection, where you have this sign. So this is a similar picture. No, lots of blood flow increase, and the patient has a continuous murmur. Classic figure of 8 snowman sign, where this is the upper part of the snowman, this is the lower part of the snowman, and this is formed by the vertical vein, the innominate vein, and the superior. So the upper part is formed by the vertical vein, which is the joining of all the pulmonary veins, the innominate vein, the superior vena cava, and the lower part is formed by the ventricles and the atria. So this is classic figure of 8. This is figure of 8. This is the vertical vein, innominate, superior vena cava, vertical vein, innominate vein, superior vena cava, which is dilated. So the upper part of 8 is formed by this confluence chamber, vertical vein, innominate, and superior vena cava. So you should be aware of what structures form the figure of 8. And you can have different kinds of snowmen, but the classic pictures that will be brought is the one here. So even this could be a picture. And some people will call it a cottage loaf also. So this is figure of 8, snowman, figure of 8, and look, cottage loaf. And what is this? This is a snowman who's facing a snowstorm. And this is what is called a snowman in the storm. This storm is because of increased pulmonary blood flow, because of plethora. Because of pulmonary plethora, you have this snowstorm, and of course you have a figure of 8, a snowstorm, or a cottage loaf sitting. So this is snowman in a storm, which is also asked in the examiner's questioning. Now, what happens to the vertical vein? It can get caught between the pulmonary artery and the trachea, cause an obstruction, and the patient can present as pulmonary venous hypertension, right-sided failure. So gross edema, pulmonary edema, and right-sided failure. The obstruction can be between the pulmonary artery and the bronchus here, and this is the main pulmonary artery, and this is known as the hemodynamic vice, because the more pulmonary arterial hypertension you have, the more dilation will be there of the pulmonary artery, and the more dilatation of the pulmonary artery, the greater will be the compression. The greater the compression, the more will be the pulmonary hypertension, and this is a hemodynamic vice, which were used in those times by thugs to strangulate, travelers, unaware travelers. They would use that device to strangulate them and kill them. So this is that device. They have drawn a similarity between that device and this occurring. And this is this is an infradiaphragmatic drainage. So that was supradiaphragmatic drainage into the SBC. The obstruction was here. And when you have an infradiaphragmatic drainage, when it is into the IVC or the hepatic or the portal veins, then of course the blood has to pass through this circulation, and therefore there will be obstruction. So the obstruction can be at the level of the diaphragm, but definitely if it is not there, then it has to be inside the portal circulation, and this patient will present with pulmonary venous hypertension of the grossest degree. And what do these obstructed TAPVCs look like? There is no significant cardiomegaly, but hepatomegaly is out of proportion. And this is the ground glass or haze appearance which you get with total anomalous pulmonary venous connection in the infant, which is obstructed variety, mostly below the diaphragm, but even upstairs, as you said, as we showed earlier. Now, this is also obstructed situation, but as was discussed last time, there could be a lot of difficulty when you have this kind of ground glass haze in the X-ray of an infant. Could this be a hyaline membrane disease? The answer is yes. You have to go by the clinical presentation. So the three differential diagnoses would be, if this kind of X-ray picture would be, one obstructive TAPVC, the other hyaline membrane disease. As you see here, the hyaline membrane disease, similar picture, ground glass haziness is there. And you have the third differential diagnosis, hypoplastic left heart syndrome, which will also give you this kind of picture. The patient would be in shock, would be cyanosed, and there will be this right atrial prominence is described when you have this haze in the presence of a hypoplastic left heart syndrome. Hypoplastic left heart syndrome, when you have obstructed situations right from the mitral to the ventricle to the aorta and down to the isthmus. So everything is obstructed the left side. So right ventricular and right atrial enlargement would be there, gross pulmonary venous hypertension giving rise to this, and there will be low output situations. It will be a duct dependent circulation. When you restore the PDA, then some kind of improvement does occur. Otherwise, the patient is not likely to pull through. So the differential diagnosis of this kind of generalized haze would be the three which we have just discussed: total anomalous pulmonary venous connection, obstructive variety, hyaline membrane disease, and the hypoplastic left heart syndrome. And this is the echo picture of the pulmonary veins, how they are draining. This is very commonly asked, that if you have a prominent coronary sinus on the left anterior LAX view, this could be unroofing of the coronary sinus, or it could be a drainage of the vertical vein, the common chamber, into the coronary. So it could be a TAPVC, which is draining into the coronary sinus. The unroofing and a dilated coronary sinus is an indication of such a situation, often asked in the examination. Whenever you're doing an echo, the examiner can ask you, well, the coronary sinus is very prominent. The other thing is, he will ask whether it is the coronary sinus or this is a descending aorta. So you have to show continuity. If it is continuous in the descending aorta, if not, then it is coronary sinus. And they will ask you the differential diagnosis of a dilated coronary sinus. So a drainage of total anomalous pulmonary venous connection into the CS is a differential diagnosis, unroofing, which will lead to cyanosis. Very classical picture. The patient presents with cyanosis. And here, the things which we are looking at is that you have a narrow pedicle and you have some cardiomegaly, and there is increased pulmonary blood flow. So this is an egg on side appearance, narrow pedicle with increased pulmonary blood flow, evidence of total of a complete transposition of great arteries. Egg on side, narrow, and the thymic shadow is absent. So the narrow pedicle, the cause of narrow pedicle is that you have pulmonary arteries and aorta sitting anterior posteriorly. There is absence of the main pulmonary artery segment, and the thymus is also absent. So because of these three situations, you have a narrow pedicle picture. No thymus, anterior posterior relationship to the great vessels, and the main pulmonary artery segment also absent. Narrow pedicle, egg on side, increased flow, and this is just to show narrow pedicle, egg on side, complete transposition of great arteries. And when we talk of the thymus, there are two signs that we talk of. One is the sail sign and the other is the wave sign. If you have the thymus and you have this kind of picture, this is the sail sign, there's another type of sail sign. This is the thymus, which tends to disappear in times of stress and cyanosed. At the moment it is corrected, the thymus can come back. And this is the sail sign because the thymus is, soft. It produces it is being indented by these, joints, and you have this. So the two signs of the thymus, one is the sail sign and the other is the wave sign. Just remember it. Maybe you're asked in the examination. Now the thymus can also sometimes be seen as this. I'm sure this is not going to be brought in the examination, but then the thymus can also present like this shadow. This is another example of transposition, narrow pedicle, egg on side type of picture, RV type of apex, and you have increased pulmonary blood flow. So the differentiated tetralogy of Fallot and DTGA, cardiomegaly, right ventricle apex similar, cardiomegaly, narrow pedicle, but increased flow here and decreased flow over here. So decreased flow is tetralogy, increased flow is detransposition. If you look at the echo, you have a circle and sausage appearance. Here in tetralogy, you will have a normal circle and sausage with RV outflow, tract obstruction seen as these shadows. While that circle and sausage will be lost, and you will have two circles in detransposition of great vessels. And the CMR will show you that the right ventricle, which is trabeculated, gives rise to the aorta. The left ventricle, which is smooth, which is fine trabeculation, gives rise to the pulmonary artery. You look at the angiogram, you find that the trabecular ventricle gives rise to the aorta, and the smooth ventricle gives rise to the pulmonary arteries. Here, the pulmonary arteries have been possibly banded. Tetralogy looks different. You'll give an angio into the RV, you see both vessels, and you see the RV outflow narrowed down. You have some kind of diminutive pulmonary arteries. The aorta is dilated. So both these vessels filling from a single injection to the RV. This is classical right anterooblique view for the tetralogy. Now, as we said, that the common features of tetralogy physiology were no cardiomegaly, decreased pulmonary blood flow, and the empty pulmonary bay except for L transposition. But here you find that there's some hump here in the region where you expected that there will be an absent pulmonary artery situation. So this is not the pulmonary artery, this is the left-sided aorta. And clinically, it is often, in the examination when we say that you must percuss the second intercostal space on the left side. If it is dull, if the patient is cyanotic and you find that the second intercostal space is dull, you thought it was tetralogy physiology, second intercostal space is dull, this means that you could possibly be dealing with an L transposition within tetralogy physiology. And this is what we have, a left-sided aorta. This left-sided aorta is seen here in this view. You see that the ascending aorta is connected to the RV and this is left-sided, hence it is levo-post aorta transposition. Once again, the smooth ventricle gives rise to the right ventricle, which has the moderator band, gives rise to the aorta. And this is the angiogram. I just sort of trying to make a variation, otherwise the X-ray can become boring. You must know that in the L transposition, the ventricle septum is vertical. Instead of being oblique, it is vertical. In tetralogy, it is horizontal. In L transposition, it's vertical. So the LV and RV are side by side. And here the LV gives rise to the, is shown filling the, but the RV actually is filling the aorta, is on the right side. And this is just to show you that is often asked that the catheters do not cross. When you put these catheters, the venous and the arterial catheters, they do not cross. If it is an L transposition, these catheters will not cross. While in tetralogy or in a normal situations, the catheters which are placed in the LV and the pulmonary arteries cross because of the position of these great vessels. On the other hand, because of the L transposition of the left-sided aorta, these catheters is going from the descending aorta, comes down to the arch, ascending and goes to the right ventricle. And the systemic, when the venous catheter goes from the inferior vena cava right atrium and goes to the left-sided ventricle. So these catheters do not cross. So that's what we are trying to say, because the septum is also vertical. It's often asked in the examination. And the septal activation is classical. You do have Q in 2-3 AVF, you don't get it in the V5, V6, which is septal activation from right to left. Another example of LTGA, you have Q waves in 2-3 AVF, and you do not have Q waves in V5, V6. So you have V1, V2 Q, you have 2-3 AVF Qs, but you don't get Qs in V5, V6, and suggestive of an abnormal septal activation as an L transposition of great arteries. And then you can have blocks also in L transposition. All kinds of blocks can be seen, as you're seeing in this ECG. Now, if you have dextroversion, we will discuss dextroversion. Dextroversion means that you have isolated dextrocardia. You have a dextrocardia, but the situs is soletus. So this is isolated dextrocardia or dextroversion. And a large number of these patients will have L transposition of great arteries. And why do you have this kind of cardiomegaly in L transposition? Because of a left-sided Epstein's anomaly, which presents with mitral regurgitation and failure. So you often in L transposition, you will have a pandiastolic systolic murmur because of a regurgitant valve, and you will have cardiomegaly because of a left-sided mitral regurgitation, left-sided Epstein's anomaly, which would mean TR normal situation, but in L transposition means mitral regurgitation, and you will have heart failure, you will have cardiomegaly. So this is just to say that dextroversion can give rise to this kind of situation. And these are the 4 comparisons. You have this is the X-ray of tetralogy, classic. This is the X-ray of tricuspid atresia, classic. This is an X-ray of L transposition, complete transposition, classical, and this is L transposition, classical. So never forget these 4, classic pictures of transpositions LD, and tetralogy and tricuspid atresia. And these are the ECGs. Classical ECG with tetralogy will have a sudden appearance of S-wave here. So shallow S-wave syndrome. Classical for tetralogy. Detransposition will have a right axis deviation, right ventricular hypertrophy. Tricuspid atresia, on the other hand, will left axis deviation and left ventricular hypertrophy. So the difference will be here in the ECGs. And L transposition we have already discussed. We will have Q waves in 2-3 AVF, V1, and absent Q waves from the lateral leads. So classical ECGs also and classical X-ray pictures, one should have no difficulty in making a differentiation of these 4 common conditions. Now, what about this? Is this Epstein's anomaly? Or is it transposition of great vessels? Because here the pedicle is narrow and there is cardiomegaly. But remember, you have to look at the lung fields. So if with a narrow pedicle and with cardiomegaly, you don't have increased pulmonary blood flow, this is not detransposition. It has to be something else. So if it is cyanosed, it has to be Epstein's anomaly. So classical Epstein's anomaly will have a reduced pulmonary blood flow. Why? Because of the functional pulmonic stenosis. So narrow pedicle will be there. There will be gross cardiomegaly, which you will not find in detranspositions. But the most important difference is the blood flow is reduced. Once again, this, you could look at this and say that this is classical detransposition. There is a pedicle is narrow, is an egg on side appearance, but look at the lung fields. The lung fields are not flooded with, there is no increased pulmonary blood flow. So if there is no increased pulmonary blood flow, but in fact a normal to reduced pulmonary blood flow, this is Epstein's anomaly. So detransposition, you will have increased pulmonary blood flow. In Epstein's anomaly, you will have no increase or even decreased pulmonary blood flow. So these are the differentiating feature would be flow. So this is detransposition and this is Epstein's anomaly. So don't call this as a transposition when you are given in the examination. Transposition would definitely have increased flow in addition to the features of narrow pedicle, some cardiomegaly and egg on side. Now, the differential diagnosis of a massive cardiomegaly are mainly three, or let us say four. One is in an infant, severe pulmonary stenosis, valvular pulmonic stenosis with heart. There is so much of severe PS that you don't get any main pulmonary artery dilatation. There's so much of PS, severe PS. And there is gross cardiomegaly with right atrial failure, right ventricular enlargement. So right atrial enlargement contributes to that cardiomegaly. So infants with severe pulmonic stenosis can give rise to this kind of picture, which one can say is because of Epstein's anomaly. But this is the differential diagnosis. In Epstein's anomaly, you're likely to have more narrow pedicle, and there will be cyanosis, which you might not find in patients with PS. So ask the history of cyanosis. If you get this kind of picture, say, is this cyanosis? No sign. If it is cyanosis, go for Epstein's. If there is no cyanosis, go for PS if it is an infant. If you think it is an adult, then you have the third differential diagnosis of a large pericardial effusion and a cardiomyopathy. So if it is an infant, no cyanosis, this kind of cardiomegaly, always keep a differential diagnosis of severe pulmonary stenosis. So the DD of Epstein's would be valvular PSN failure, rheumatic heart disease, as I said, multivalvular disease, a pericardial effusion, cardiomyopathy, Wool's anomaly, and endomyocardial fibrosis. So basically these four, this of course you can mention. Now, if you have cardiomegaly with the main pulmonary artery dilatation and there is no increased pulmonary blood flow, what do you think you have? Definitely there is no increased flow and the main pulmonary artery is dilated. So you have only one diagnosis, and that is that of pulmonary stenosis. Now we will come to a differential diagnosis of this situation. Now you can say that this is dilated main pulmonary artery. It could be pulmonary arterial hypertension. Why do you say it is pulmonic stenosis? Why I say pulmonic stenosis is because in pulmonary hypertension, in addition to the main pulmonary artery dilatation, you are also wanting to have a right pulmonary artery dilatation, which is not there. So if you have a main pulmonary artery dilatation, but no right pulmonary artery, you are not dealing with pulmonary arterial hypertension. This is pulmonary valvular stenosis. And this dilatation is because of right atrial enlargement. Now, suppose I add cyanosis here, this becomes triology of Fallot, where you have valvular pulmonic stenosis and reversal of shunt through the atrial septal defect or a PFO. If there is no cyanosis, it is valvular PS alone. If there is cyanosis, it is reversal through an ASD or PFO, the so-called triology of Fallot. This is Epstein's, of course, the box shape because of right atrial enlargement and RV outflow enlargement. Classical Epstein's. This is the CT of Epstein's. You find that there is a dilatation And this is the abscess which you often get, the infarct and the abscesses which you get in Epstein's because of the paradoxical embolism. And this is the classical X-ray where you have notching of the QRS, classical ECG where you have notching of the QRS. So this is Epstein's anomaly, no doubt about that. And then you know the differential diagnosis of, if it is an infant and without cyanosis, it is severe PS. If it is an adult with no cyanosis, it could be pericardial effusion or a cardiomyopathy or a valvular heart disease. So all these things you have to keep in mind. Is this Epstein's anomaly? No. This is pericardial effusion. One of the close differential diagnosis. If there is no cyanosis, of course, this is not. And this is an adult, so this is not Epstein's. This is a bag-shaped pericardial effusion. And this is what you get on this EMR. You have this heart shadow and you have pericardial effusion. And this is what you see on the echo. And this is what you get on the echo. You have a large pericardial effusion. And this is the ECG. You get low voltage ECG in your examination. So this is classical pericardial effusion. And what is this? Is a very classical swinging heart situation. And this is the type of ECG we will get. One complex small, whether big, or one positive, one negative, so-called malignant pericardial effusion, where you have alternance. And this is because of the heart is swinging so badly inside a huge pericardial effusion. And you can, this is a fetal echo. Before we because we have very little time, I think we can just revise in 5 minutes how you interpret the X-ray on the congenital heart. So instead of going through the curiosities, which I have too many of them, and subsequently in a further lecture, perhaps I can take them up. But let me just summarize in about 5 minutes. So start your interpretation of the X-ray with the pulmonary artery. I always say, start your interpretation with the pulmonary artery. Now, if your main pulmonary artery segment is empty, you're dealing with a situation of tetralogy physiology. Now, within tetralogy physiology, you have seen those 4 categories which I showed. It could be tetralogy of Fallot, it could be T transposition, it could be L transposition, or it could be a tricuspid atresia. And these were the classic X-rays and ECGs which we have just discussed. So this is a tetralogy physiology if the main pulmonary artery segment is absent. On the other hand, if the main pulmonary artery segment is full, you are dealing with either a pulmonic stenosis situation or a pulmonary arterial hypertension situation. So then the next thing is to look at the right pulmonary artery. Now, if the right pulmonary artery is present, this is pulmonary arterial hypertension. And if the right pulmonary artery is absent, it is pulmonic stenosis. Very simple. So this is how I would ask you to proceed. Look at the main pulmonary artery segment, present or absent, present, PS or PH. Then look at the right pulmonary artery. If it is present, it is PH. Otherwise, it is PS. And these are the angiograms. You have a diminutive right pulmonary artery in PS, but you have a prominent artery in. So main pulmonary artery would be prominent in both, but the right pulmonary artery is prominent in PH. It is diminutive or small in pulmonic stenosis. Cyanosis with cardiomegaly, we have just discussed. This is main pulmonary artery. Let's start on the principles we have discussed. Main pulmonary artery is prominent. Is this PS or PH? The right pulmonary artery is absent, so this is likely to be PS. Now, if it is valvular PS and there is no cyanosis, it is plain and simple PS. If it is cyanosis, this is triology, that is reversal through an ASD or a PFO. Cardiomegaly with cyanosis, triology or Epstein's. The differentiation is very easy. If you have cardiomegaly with cyanosis, can it be Epstein's? Can it be triology? Main pulmonary artery segment is prominent in triology. It is not there in Epstein's. So this functional MS, PS is there in Epstein's. So there is absolutely no difficulty in saying which is which. Valvular PS reversal and Epstein's anomaly. No main pulmonary artery segment. Cyanosis with no significant cardiomegaly is Eisenmenger. So cyanosis with cardiomegaly is triology or Epstein's. Cyanosis with no cardiomegaly is Eisenmenger, except for an ASD Eisenmenger situation where you will have cardiomegaly. And to differentiate, I said no aorta, likely to be ventricular septal defect. No significant cardiomegaly, aorta is not there, likely to be VSD Eisenmenger. Aorta prominent, no significant cardiomegaly, likely to be PDA. Neither aorta, but cardiomegaly and right atrial enlargement, likely to be NASD, Eisenmenger. So I think with that we are done with the cyanotic heart diseases, and then we have lots of X-rays which are curiosities and calcification. Maybe in a subsequent, whenever we have time, we can discuss them. So with that, I would say that we are mostly done with what we had to discuss and finished mostly in time, another 10 minutes overshoot. So if you have questions on that, then we can take them up, or whatever you want me to do. So thank you very much once again. Thank you, Dr. Mohit.
Thank you so much, sir. And it's like, we have just taken a dip in the ocean of knowledge, and it was amazing to see the curiosities. In fact, most of them we have even seen for the first time. So it was very exciting to see all of them, and your systematic approach will help all the students and many of the people, more than 200, 300 people who have joined now, who are live now, will actually understand that how to approach the X-ray becomes sometimes a major problem, especially when you get a mandatory case of a congenital heart disease. It was absolute terrific to listen to you. We have Sumod, Girish, Sanjeev, and Deepthi along with us. So I would request them to please, ask any questions. And one of the questions by Dr. Gopal Krishna from Bangalore is saying is that then can these regular and the Euler ratios be applied to a digital X-ray?
No, I don't think so.
So these are
you have to have, as I said, you have to have penetrated views. You can play around with digitals. In fact, I take back what I have just said. Digital X-rays are bad for decreased flow and increased flow. But when you have to look at these regulars and these ratios, the Euler ratios, then if you take a penetrated view, then perhaps the IVC can be seen better. So these measurements can be perhaps made better when you have a digital X-ray. And you can even see the ratios. As I said, the Euler ratio will be not difficult when you have. But yes, if they are not at a proper distance, and you want to sort of make your assumptions as to 6 feet away or not 6 feet away, closer to the heart, sitting up while the patient is in bed, then perhaps they will not be applied. But if they're taken at a proper distance, then digital X-rays with more penetration, I think they will show you the IVC better, and you will be able to make those regulars as well as the Eulers obviously in a better way.
And this Epstein's anomaly, typical X-ray, and the pericardial effusion, these are often called as the wall-to-wall heart, right?
That's right.
So, one of the questions that again is coming is that how do you differentiate between the X-ray of the pericardial effusion versus the Epstein's?
Pericardial effusion, you will have a clearly defined border, and then you have to say whether the patient is cyanosed or non-cyanosed, and then some kind of, if you look at the costophrenic angles, the costophrenic angles will be more well defined in pericardial effusions as well, besides the Epstein's. But yes, the history is important. Actually, whenever we give the X-ray in the examination, we tend to give some kind of history also. And that is why I said when you have massive cardiomegaly, then always discuss the differential diagnosis. If it is an infant with cardiomegaly, think of PS with failure. In an adult, think of pericardial effusion, Epstein's anomaly. If there's cyanosis, talk of Epstein's. If there is no cyanosis, talk of pericardial effusion. But in cases of pericardial effusion, the borders are really well defined. The borders are really well defined. And the cardiomegaly is perhaps a little more than what you get in Epstein's. And the costophrenic angles perhaps are clearer in Epstein's as well, in vis-a-vis the pericardial effusion. I mean, these are some of the subtle differences, but yes, I think the history is more important. If you have anything else in mind, then perhaps you can, give me the feedback. We always learn from each other. So if you want, Mohit, if you want to say something.
Sumod, anything else? Deepthi?
No. Epstein, generally they say stencil and a bilkul sharp.
Stencil.
Yeah, that's what I said. If you have a very...
Yeah.
No, but that happens even with pericardial effusions because of the, because the contractions are not occurring. So you have a very clear-cut border even with pericardials. So maybe that is the difference.
Yeah.
But I think basically it is the historical part. The patient is not cyanosed in adult and perhaps. And then you always have the clinical findings in the echo. I mean, in Epstein's is not difficult to miss. If you have that kind of Epstein's, a classic Epstein's, then a spit 1, a spit 2, S3, S4 will always be there, and murmur would be there, which you will not get in pericardial. And then, of course, the moment you put your transducer on the chest, you know it is pericardial Epstein's. But yes, X-ray wise, sometimes you might be foxed.
Sir,
Mhm.
sir, can we use the word pulmonary bay? Like, is this word specifically to be used only in TOF, or we can use it whenever you have a?
No, pulmonary bay is the area where the pulmonary arteries are parked. So if the main pulmonary artery disappears, the bay is empty. If it is parked there, it is full. So bay simply means an area which is used for parking the main pulmonary artery, to my mind. So I say the pulmonary bay is full or the pulmonary bay is empty.
So we commonly say pedicle is narrow. Is that it's a subjective thing, or it is a definition for narrow?
Yeah, some people ask that definition. I will not be able to answer what is the definition for a narrow pedicle. And the measurement I am not aware of. But basically, I know that the reasons are the ones which I have enumerated: the anterior-posterior relationship, the absence of the pulmonary artery, and the absence of thymus. So if you are aware of any measurement, then you can let me know. I'm not aware actually of any criteria which I would use to say. Basically, it's subjective. But do people ask about that measurement? We can actually look it up, sir.
I had tried to look it up for it.
Yeah, please.
Wherever the vesical pedicle is mentioned, they've mentioned the value of 43 to 53 is normal. More than 53 is increased.
So that is okay.
I'm not sure from
you
where
use the same measurement which we had discussed for the aortic knuckle, that you draw a line from the lateral border to the. So that is the criteria which they use to say it narrow. Okay. So I think that's a good idea. That what the criteria which you use to say that it is increased, if you're less than that, then it is narrower.
That's what I read somewhere. I'm
Okay.
not sure from where it is.
That's correct. If it is less than 35, then it is narrow. If it is more than 35, it is prominent. So, how much did you say it was?
It was, as I remember, 43 to 53 is normal.
Less than 35 is the figure that I have read, but maybe different places they do it differently.
No, sir. This is actually, I am reading from Radiopedia.
Okay.
So the normal range is 38 to 58.
Yeah, that's somewhere around 35 or something.
So you're absolutely right. 35 and less would be narrow vascular pedicle.
Okay. I think that's fair enough.
Yes.
So another question from Lakshdeep. Dr. Rahul is asking how to see infundibular enlargement in X-ray.
Infundibular enlargement on the X-ray will be very difficult to see, but one of the reasons of prominence of the RV, one of the reasons of the fullness of the pulmonary bay in tetralogy has been described as dilatation of the RV outflow tract. Post surgery, if you have dilatation of the right pulmonary outflow tract, right outflow tract, right ventricular outflow tract, you can have prominence in that area.
Sometimes in EMF also they may mention there could be only the.
You what? What fold?
EMF, endomyocardial fibrosis also. Sometimes only the infundibular could be.
Yeah, and that is seen as an area, in the pulmonary area, the fullness in the pulmonary area and reduced pulmonary blood flow situations can be because of the dilated RV outflow tract. So RV outflow tract prominence will be seen in the PA view as an area of fullness in the pulmonary region. That's about all that I can say. Because when you discuss the differential diagnosis of prominences in the pulmonary area and tetralogy physiology situations, then one of the causes is dilatation of the RV outflow tract, in addition to the absent main pulmonary artery, and because of collaterals when you have the main pulmonary artery segment prominent. So one of the differential diagnoses is dilated RV outflow tract. And that is what you get in Epstein's. The area which is prominent leads to that box shaped in Epstein's is because of the dilated RB outflow. So I think that is the area that you will have to specifically be looking at. The dilatation of the, as asked by a doctor from Lakshadweep. I think just below the pulmonary artery is that area you should be looking at. So that is the area which gives a box shape in the Epstein's and a fullness in cases of tetralogy of Fallot.
And other things which can be added besides the pulmonary plethora bird and the polygemia is the pulmonary pleonemia.
Yeah, that's been discussed last time. That you have unilateral. There are so many causes. You can have increased, you can decreased, you can have normal. So when you have inequality of the lungs flow, it is pleonemia. We discussed that last time.
Yes, yes.
Thank you so much, sir. It was again, as usual, everybody would resonate with me, agree with me that it was a treat to listen to you. And
it was fun.
The residents, we are not reading the praise and the thank you messages that we are getting. We are only asking you the questions, and thank you so much. It's been such a pleasure. But let me tell you, sir, your association with the PG track is just a beginning with the first 2 sessions, and we'll keep on bothering you for more sessions, because your academic knowledge needs to be disseminated to the fellows across the country and not limited to few of them. So on the behalf of the PG track program of the Delhi CSI, it's an absolute pleasure to have you, and from all our heart we really thank you on the behalf of the panel. And to all my friends and the residents who have joined, just have a look at this, that this weekend we are going to have the 34th annual conference of the Cardiological Society of India Delhi branch. And this particular conference is not only designed for the physicians and the cardiologists, but also for the fellows. We are having the clinical sessions on the management strategies of the common problems, on the hypertension controversies, on the dual antiplatelet therapy, or the heart failure update, and along with the rhythms, the lipid saga, and the division well, the common debates, all these. And for you fellows, we are having a specially program designed in the second hall, which is the Cardio Prime, on the hemodynamic support. We'll be talking and teaching you about the Impella, about the ECMO, what are the current indications, case-based approach. We'll be talking about the basics and the advanced intravascular lithotripsy, how you crack the calcium, what are the newer modes of pacing, the physiologic pacing, in the simple language by the best experts who can explain you. Then we'll also be talking on Sunday on the imaging, the intravascular ultrasound, the optical coherence tomography, the MLD Max algorithm, and all those all in store for you. I've been posting these things on your groups, and I request you all to register for the conference. It's all free. We only need your time. This has been specifically designed keeping you in mind, and I really look forward on the behalf of Delhi CSI to have you there on the weekend. So on the behalf of Delhi CSI, hope to catch up with you on the weekend. Thank you so much, everybody. Thank you, sir. Thank you so much. And next Thursday, we'll come up again with a beautiful session. This time we are planning something out of the box. I'll be sharing the details soon with you once that we have the confirmation. Thank you so much for joining today evening. Thank you. Goodbye. Have a good weekend.
Thank you. Thank you very much. It was a pleasure. Pleasure to you.
Thank you.